Welcome everyone. A few people still coming in here. I'm going to go ahead and share my screen before I start. Okay, I'll go ahead and start introducing everything here. Before I introduce our guest of honor, I'll tell you a little bit about myself. I'm Chris Edwards. I'm the founder of soQuiet, and I am not a researcher. I have a background in theater, but I have struggled with misophonia for most of my life, if not all of my life, as far back as I can remember. I'm 48. And we do these science sessions as a way of highlighting and learning to understand and communicating all of the research that's happening in the misophonia world. There's been a lot of great research coming out in the last few years. There's a lot more coming up. And so we try to communicate that through these. Me as a layperson, I maybe have sort of non-academic questions, and hopefully as I learn through these, you all do too about the research on misophonia. A couple of ground rules real quick. You can see my screen. Please keep your cameras off and your mics on mute. We are not in a lecture setting in Google Meet. This is actually one huge meeting. But if you can keep your cameras off and your microphones on mute, I will make judicious use of the mute as well if I'm not speaking. But this is to reduce unintentional misophonia activators and make the event more accessible. If we're all on camera, you never know when one person in some window off on the side might be doing something that is triggering, so we just try to reduce that a little bit. Please put questions in the chat. We are joined by Michelle, who is also one of our board members. She will be our stage manager, monitoring the chat for questions or issues. If there's something that you find that we're doing or I'm doing that's triggering, please let us know, and Michelle will keep up with that. She will also be adding supplementary materials throughout our discussion today. So if there's any links to other studies or other articles, so on of note, she'll put those in chat. It's greatly appreciated. She's a librarian, so this is what she's exceptional at. Also, feel free to use the closed captioning here in Google Meet. At the bottom of your browser screen or whatever you're in, there should be a little box that says CC. That's for closed captioning. That provides automatic transcriptions of what we're saying during this particular session. And so if there, maybe there's something that's triggering, maybe my voice or whatever it is, you can put the whole thing on mute and you can read what we're saying in real time. It kind of helps make it a little more accessible too. Also keep in mind that this event is being recorded. So we will post a recording of this on our website and our YouTube channel in the next couple of days. So you can come back and watch it or watch it if you're not able to catch the whole thing. Some things about soQuiet and misophonia research. We're located in the United States. We're a nonprofit organization or an NGO if you're outside of the US. We have numerous things that we do for research. One of them is misophonia student research grants. This is up to $1,200 that we offer to graduate students so that they can undertake misophonia research. We just awarded 2 of those in the last month. It's very exciting. It's one of the things I love doing the most. And it helps accelerate early career researchers and get them on the path to providing us with more information. We also have the misophonia research pool. This is the only centralized, unaffiliated misophonia research participant registry. This is free for everyone to use. So if you want to participate in misophonia studies at some point, or you're a researcher who needs people who want to participate, we just match up those 2 needs through the pool. And lastly, soQuiet Science Sessions, which is what we're doing right now. This is where I learn about the latest in misophonia research, and by extension, you in the audience also do. We'll have a Q&A towards the end, but if you have any questions throughout this, feel free to drop them in chat, and Michelle will let us know when those happen. All of our programs are free, thanks to taxable deductible donations. If you want to donate, you can do that at soQuiet.org/donate, or you can text the word soQuiet to 53555 and make a tax-deductible donation right on your phone. It's so handy. If you have any questions or comments or concerns about this, we're always happy to hear from you. You can email hello@soQuiet.org. We respond to every email, and everything we do comes from the input that we receive from the Misophonia community. That's people like you. So let us know how we can help. And now I'd like to introduce our guest of honor, Dr. Hashir Aazh. Let me stop presenting here. Hashir, if you wouldn't mind introducing yourself and tell us a little bit about what you do and how you came to misophonia, and we'll go from there.
Yeah, well, thank you very much for having me. Yeah, my name is Hashir Aazh, and I'm an audiologist by training. And I was in quite early in my career, I became interested in tinnitus. And as I was studying tinnitus and helping patients with tinnitus, I also came across hyperacusis and misophonia. And ever since, I've been working on these three conditions as my main part of work, whether it is clinical practice or if it is research, or the conference that we have, which is the International Conference on Hyperacusis and Misophonia. And so it's a field that I'm really interested to learn about and help people who are experiencing this condition.
All right, thank you so much. And before we start, you had messaged me that you all are doing an event this summer and you're looking for input from the misophonia community, which we can get through social media, but I'm also wondering if we can do that during this event. So what kind of input do you need as far as what you'd like to cover for this event that you all are hosting this summer?
For the event, my colleague, Dr. Mercede Erfanian, is in charge of that event. And so I do not exactly know what is it that she has planned. And so I think we have to wait and to be guided by her later on whenever she gets in touch with you.
I'll reach out to Mercede. All right. Thank you so much. It's a pleasure. What we're going to be talking about mainly today is a couple of your recent papers, although you have quite a few published papers on misophonia that cover everything from treatments through cognitive behavioral therapy to assessments in audiological settings. And the one we'll be talking about mostly today that I've read, I can't say I understood all of it, but is called Audiological and Other Factors Predicting the Presence of Misophonia Symptoms Among a Clinical Population Seeking Help for Tinnitus and or Hyperacusis from 2022. And I thought this was really fascinating. You actually wrote this paper with Mercede, and as well as Ali Danesh and a few other folks that are on a lot of studies. I see your names pop up quite a bit. And tell us a little bit about this. And I have some questions as a complete novice in this field. Tell us a little bit about what instigated this study and why it began, and then we'll talk about what the results are and some things that stuck out to me.
Yeah, that's so I have done because in the clinics that we had, originally the clinics were designed for tinnitus patients and then hyperacusis, but for many years we didn't really classify misophonia as a separate condition to hyperacusis, and it was always hyperacusis having different categories. Some of them are sensitive to the loudness of the sounds, which became like loudness hyperacusis, and some people were having dislike of certain sounds, which fit well with the definition of misophonia. So in a lot of my research studies, although there were patients with misophonia within those groups, but they were not have a distinct category of misophonia. And so I was very much into this idea that there is really not much of a point to have misophonia as a separate condition, because it's an intolerance to certain sounds, so as the hyperacusis. So these were all under the same category. And it didn't really matter that much at that point of time, in my view, that a person with misophonia has this type of reaction to this type of noise. A person who with hyperacusis have a different type of reaction to different type of noise. All of them were having a reaction to certain sounds. and those reactions were interrupting their day-to-day activities, or it was impacting on their life or their mood in general. So that was the key for me, a reaction to certain sounds that was impacting on the person's day-to-day life. And this was kind of, it fit well with both people who had hyperacusis and people who had misophonia. And also there's another type of this sound intolerance, which was people who had high level of noise sensitivity, because noise sensitivity is categorized as a personality trait if you look at literature related to environment and noise pollution and stuff like that. And people who have noise sensitivity, they find it hard to tolerate the certain noises related to the neighborhood, noise from the neighborhood, distant airports, train stations, industrial facilities, cracking and pipe work in the house, air conditioning, things like this. These are noise sensitivity issues. So as far as I was concerned, it is about a reaction to certain type of sounds in a way that it impacts on the life of the person. If it didn't impact on the life of the person, I wouldn't classify it as misophonia, hyperacusis, or noise sensitivity. I would say this is just the differences between the people. So the key was it needed to impact on the life of the person for it to be a diagnosable condition. And so this was basically my thinking. That's why I wasn't really subclassifying misophonia to hyperacusis. And I resisted that for 10 years or so. And in all of my papers, we're talking about tinnitus and hyperacusis, misophonia being a subtype of that. And but misophonia, the term misophonia, was so well taken by people who actually were experiencing this condition, and that their power of expressing and using this name was far beyond my resistance. So after 10 years or so, I given up. And I said, okay, that's fine. I agree. Misophonia, I'm not going to subcategorize it in under hyperacusis. And so I actually started using it more frequently, the term misophonia. And it didn't make a difference in the actual work that we were doing, but I think it was right, because people who were experiencing that, they did not really identify themselves as having a subtype of hyperacusis, and they were clearly defining this as identified this as misophonia. So I agreed with that, and since then most of the studies have also included the term misophonia into to the mix, if you like. And the study that you mentioned is one of those studies, and this was in a clinical population of patients with tinnitus, and they're using certain questions, like a checklist on a questionnaire that we have called Sound Sensitivity Symptoms Questionnaire, SSSQ. And on that questionnaire, item number 4, asking about misophonia, basically. So based on that question, we were able to see how frequently people who have tinnitus and seeking help because of their tinnitus were also experiencing symptoms of misophonia. And we used a lot of the statistical modeling in order to work out what is related to what audiological factor, what tinnitus severity, what hyperacusis factors, and as well as mental health measures are related to frequency of experience of misophonia among this population of patients, who all of them had tinnitus. And so just over 20% of people who were seen in that clinic is, I think it was just over 250 people who were in that period of time were seen in the clinic. So about 20% of them had symptoms of misophonia, a wide range of symptoms, and some of them were, their misophonia was basically the main problem, the main complaint. But here in the UK, if the complaint is misophonia or hyperacusis or tinnitus, all will be referred to a tinnitus clinic. They may or may not have tinnitus, and but in this population of patients, in that particular study, we used all of the people who had tinnitus. So, and that 20% of them also had symptoms of misophonia, various degrees of this. And in an audiological setting that we were working at that time, we were doing Puritan audiometry, which is a test of hearing in which we can identify the quietest sounds that a person can hear. And we measure them in decibel, HL, which is hearing level. And so at different frequencies, from lower frequencies like 250 hertz, all the way up to 8,000 hertz. And so in each frequency, we knew that what is the estimated hearing level of that individual. And we measure right and left ear separately. And usually when we have a hearing loss, the way that our hearing deteriorates is not going to be the same across all of the frequencies, unless there is a conductive element, like if you have a glue ear or impacted earwax in your ears, or maybe your eardrum is damaged, or the ossicles in your middle ear are broken. And then those sort of conductive hearing loss, which basically doesn't let the sound to travel into the inner ear, those type of hearing loss usually give you a hearing loss pretty much at the same level across the frequency range. But other types of hearing loss, which are related to the inner ear and loss of the cells inside our inner ear, they can be in a particular frequency. So they can be, a person can have hearing loss at higher frequencies, so they can't hear really the pitch, high pitch sounds, and they lose some of the clarity of sounds that they hear. And if it is progressive, then it will reach us to the speech range, then they lose hearing the consonants in the speech. And that's where they need to use hearing aids, because they will not be able to discriminate sounds. Some other conditions, the hearing losses start from the lower frequencies, like Meniere's disease. And so in those conditions, they will not be able to hear the low pitch sounds, and that has its own effect as well. So we had all of this information to see how is the hearing of each individual who were seen in that clinic. And we also had their frequency of experiencing misophonia symptoms based on the SSSQ questionnaire. And so we could basically see people who have misophonia compared to those who do not. Is the hearing any different in any frequencies? And so that was a question. Another audiological measures which we took into account was uncomfortable loudness levels, because majority of all of these people have tinnitus. As a part of the tinnitus assessment, we measured uncomfortable loudness levels, and that is the level of the sound that the person feel that sound is too loud. And so the exact opposite of the thresholds of hearing, which would be the lowest level of sound that they can hear. The uncomfortable loudness levels, or ULLs, is the loudest sounds that they say, that's okay for me to listen to. Beyond this, it will be too uncomfortable for me to listen to that. And so we were measuring those thresholds also in different frequencies, 250, 500, 1000, 2000, 3000, 4000, and 6,000 and 8,000 hertz. So we also could to see if people with misophonia are finding certain frequency of the sound harder and more uncomfortable when they are listening in that test. As a part of the tinnitus management process that we had, patient had to fill in various forms of questionnaires assessing the impact of the tinnitus on their life using a questionnaire called Tinnitus Impact Questionnaire, and symptoms of hyperacusis, as well as the impact of hyperacusis using a questionnaire called Hyperacusis Impact Questionnaire, and also a measure of anxiety, a screening measure of anxiety and depression and tinnitus, which is called SAD-T. So they were completing all of these questionnaires as a part of their routine care as well. So we had a bulk of audiological data, as well as this person, do they have symptoms of misophonia or not, or how frequently they are experiencing such symptoms, plus their responses to these questionnaires. So we could then categorize people who had reasonably significant symptoms of misophonia and people who did not have any symptoms or just one-off symptoms to two categories, and then make a comparison between hearing thresholds between these two groups, uncomfortable loudness levels, anxiety and depression symptoms, hyperacusis measures, tinnitus measures. Was it more severe in people who also had misophonia compared to people who just had tinnitus with no misophonia component? And we didn't even know what would be the result of such analysis. And so that was kind of made it interesting. I don't know, I'll leave it to you to, if you have any question to ask. I have the table that actually shows the comparison between these two. After you ask your questions, Chris, if there is anything, I can go and show the table and explain what is it about.
Okay, yeah, thank you so much for that. Michelle put the link to the study, but yeah, we can share the table as well. A few things that struck me about your paper in this study are, one, we're at a point, just to kind of go back, when misophonia was first recognized or coined in around 2001, it was by audiologists, the Jastroboffs, and for about the first 12 or 13 years, it was viewed as a largely audiological condition. It kind of morphed between about 2014 and 2015 to where it was thought of as more of a psychological thing. And in the last few years, it seems like neurobiologists have kind of come in and said, oh, we've got these brain scans. But here you make a good point at the introduction to this paper saying we can bring back the audiological aspect of it. If people are suffering from misophonia, whether they know what it is or not, they're most likely to see an audiologist first, just for lack of knowing who to go to. And your assessment of people coming in was very interesting to me, in that you do have a single question that could lead you to assessing them for misophonia, but this seems like something that audiologists might be interested in doing just for all of their patients. Ask them a single open-ended misophonia question to see if they need to delve a little further into that, to differentiate it from hyperacusis. And I don't know that that's something that necessarily always happens, but I found those aspects of your paper really interesting. Real quick, for the folks in our audience who maybe aren't quite sure, because we get asked this a lot, how would you describe the differences between hyperacusis and misophonia? A lot of people get them kind of mixed up because they seem really similar, but now we know them as distinctly different things.
Yeah, that's actually a good question. And let me just, I think I have some sort of a definition for these, if I have the slide in front. Yeah. So is that okay if I share my screen?
Yeah, sure. You should have a little arrow that says present now, and then you can share your screen.
Share a screen.
Hopefully it works.
Yeah, this is, in this slide, I have the criteria. So to just a quick point about your comments, in actual clinical practice, we do not only rely on one question to diagnose misophonia, but for that particular research study, because it was a retrospective study, and the data that was available were people's answers to that particular question in the questionnaire that they completed. So basically, we use that as the measure to say how frequently this person were experiencing misophonia symptoms. And majority of people working that are specialized in tinnitus, and they do ask at least a single question in order to find out if the person has any symptoms of misophonia. But in general, it would be very hard to make a diagnosis for misophonia or hyperacusis based on a question or even a full questionnaire. And because the way that people answer the questionnaires, although it has gone through quite a lengthy process of being validated and reliable, so on and so forth, but still, it can't really give. There are many people who may score very highly on a particular questionnaire, but when you perform a clinical interview with that person, you realize that what the answers on that questionnaire might have been misunderstood or exaggerated, or have not expressed in as bad as it really was. So the gold standard, in my view, for making the diagnosis for these conditions is based on an in-depth interview that you do with your patients, and that can take almost about an hour. And that is after you have all of the informations, tests, and everything already gathered. Then you spend about 1 hour with these patients in order to understand whether they have hyperacusis or misophonia in the way that it is shown in this slide that I'm sharing with you. And this is the criteria that we have for hyperacusis. So the hyperacusis may be diagnosed if the person shows at least one of the first 4 characteristics listed below, in addition to characteristics number 5 to 9. So they need to either have sound intolerance adversely affect on day-to-day activities, or sound intolerance affects on their mood, or sound intolerance affects on their resting and relaxation, or the person uses avoidance behaviors or rituals in order to cope with sounds that bother them. So at least one of these needs to be present, because the person may not, sound intolerance may not affect on the person's activity, mood, or relaxation, because they always are avoiding the situation. So that doesn't. So then this one is still the case. So you have at least one of these 4. It could be for many people that sound intolerance meets all these 4. Number 1 to 4, which is the majority of the cases. But at least one of these needs to be met, plus the rest of these. So what are the rest of these? The rest of these are mainly to make that distinction between hyperacusis, misophonia, and noise sensitivity. So the person perceives some sounds as too loud, uncomfortable, or painful. This must be present for them to be classified as hyperacusis. The person's main complaint is not decreased tolerance to oral nasal sounds. So the main complaint is not the misophonia triggers. This also needs to be met. The person's sound intolerance is not better explained by their general attitude toward noise and environmental noise pollutions, like noise from neighbors, nearby airport, traffic, workshop, internal plumbing, or air conditioning. So this to exclude noise sensitivity. If the person uses hearing aids, the sound intolerance is experienced even if they are not using the hearing aids. So the sound intolerance, the complaint of sound intolerance is not because of a hearing aid, for example. And then the last is that the symptoms are not better explained by any other medical or psychosocial conditions. So these are the criteria that we go through, and it is very hard to establish that these are really the case. And that is why that interview can take a long time, if you like. For misophonia, the misophonia may be diagnosed if the person shows at least one of the first 4 plus 5 to 8. So a similar sort of thing. Sound intolerance, so the first 4 are pretty much identical with hyperacusis, and then the rest of them goes to exclude hyperacusis and focus on misophonia. The persons must perceive the specific sound as disgusting, offensive, or annoying. Their primary reaction to sound is not that of oral pain or physical discomfort in the ears due to excessive loudness of sounds. The person's sound intolerance is not better explained by noise sensitivity, and the symptoms are not better explained by any other underlying medical or psychosocial condition. And this final item is also tremendously important in making a distinction between an experience of misophonia, hyperacusis with other problems such as personality disorders, psychosis, hearing imbalance disorders, so on and so forth. So this is also an important aspect of this interview. So this is basically how we make the distinction between these two conditions.
Gotcha. Thank you for explaining that. Yeah, I know just in layperson's terms, there's a lot of confusion, but hyperacusis is more about volume and physical pain, if I way overgeneralize it. And misophonia is oftentimes about quieter sounds and is more of an emotional or physiological reaction as opposed to physical pain. Is that a good way of kind of just wrapping it up in basic terms, or?
Yes, exactly. Like misophonia, I'm sure people who are in this meeting know what the experience of misophonia is. But hyperacusis is like, for example, a person with hyperacusis will find it very hard to use a hand dryer in a public toilet because of that noise. And if you see children covering their ears, it's probably at the beginning of developing hyperacusis. And you know what parents do at that stage can determine whether this person gradually will become wanting to isolate themselves from loud noises, which can lead into hyperacusis or not. But the hyperacusis can be developed for lots of other reasons, some medical conditions like Bell's palsy, Lyme disease, comorbidity with tinnitus, and so lots of other reasons. Also, depression has shown to have a significant relationship with hyperacusis, and so the conditions are different, and but sometimes can be overlapping. At least they overlap in that first four criteria, if you like. That's the thing. But then the other four criteria, or 4, 5, 9 criteria.
You distinguish them by those last few criteria. Okay, that's good to know. Thanks for explaining that.
Hey, Chris, we have a question in the chat.
Sure.
Somebody's asking, has anyone found a support group that they would recommend? So I just dropped the link for our peer support groups that are in the works, but you want to add anything to that?
Dr. Aazh, I know there's a few support groups for people with misophonia in the UK. Are there any that you're familiar with, or maybe that you host? And if not, that's okay too.
Yes, at this moment, I do not have any particular one in mind, but I know that there's quite a few of them around.
Yeah, and you can email us, and I'll reach out to our UK advisors for some help. But yeah, we will be starting peer support groups here shortly. Before we move on to the consensus definition, you had a recently published commentary on that. This particular study that we've been covering, you did find some novel findings, I guess. There were a few things that came out of it after analyzing all of the data that was pre-existing for this particular study. What are a couple of those novel findings that you found that you mentioned in the paper that you thought were unique?
Yes, that's I just wanted to share with you the table. One of the tables had many tables. One of the tables is this one, which we categorize people to two groups: meso-cat 0, the people who did not have misophonia symptoms or had very limited frequency of them, and meso-cat 1 were people who had misophonia symptoms at least half of the days. So 50% of the time they were, or more, they were experiencing misophonia symptoms. And then we assessed various different factors between these two groups to see whether these are different or not. And one of the things was the ULL value. So uncomfortable loudness levels were 79 decibel in the group that they did not have misophonia, compared to the one that they meso-cat 1, 74. So this means that people who were in the misophonia group, they had less tolerance of the sounds. So the sounds became uncomfortable for them sooner than the people who did not have misophonia. And this is a feature that you also see in hyperacusis. And the difference between these two groups were statistically significant. And the other things which were interesting were the slope of the uncomfortable loudness levels. And the slope of this measure means that was there any difference between different frequencies? Like, for example, somebody's uncomfortable loudness levels for frequency of 1000 hertz may be very, they can tolerate it very well, but a higher frequency sound like 8000 hertz, they may find it harder to tolerate. And because these two frequencies on the audiogram, they are at different places, so we calculated the slope for that particular test. We also calculated the slope for the audiogram, which basically shows if the person has a high frequency hearing loss or a low frequency hearing loss. But overall, people who had more steeply sloping uncomfortable loudness levels, as well as more steeply sloping audiograms, let me just say one by one because it confuses even me. People who had more steeply sloping uncomfortable loudness levels, they were in the group of misophonia compared to had less difference. So the more variations in uncomfortable loudness level thresholds, like being sensitive to 8000 hertz as opposed to being sensitive to 1000 hertz and 8000 hertz, was a feature in the group of misophonia. So they were sensitive to particular frequencies of sounds, and this was a significant difference between the two. And the other thing which was interesting was the slope of the audiogram. People who had a steeply sloping audiogram, so in a way not hearing high frequencies very well, and they were in the group of no misophonia, and people who had less steeply sloping audiogram, in a way being able to hear high frequencies better, and they were in the group of misophonia. So hearing loss basically was less prevalent among people who had misophonia compared to people who did not have misophonia. And I think this is an important thing to consider, that because, you know, if you do not have time to do all type of tests for your patients, and patients coming to the clinic with main complaint of misophonia, there is very little evidence that suggests that they need a hearing test, because their hearing is probably better than a person without misophonia. And I think that this is something that can save time of people and their money if they have to pay for these tests. Other interesting things were the group of misophonia who also had tinnitus. Their tinnitus was worse than those who didn't have misophonia. Same for hyperacusis. Their hyperacusis were worse, and the anxiety and depression symptoms were worse as well. But the group of misophonia were overall a bit younger than a group who did not have any misophonia symptoms.
Interesting. Yeah, I've heard that, and it's something that's still being figured out. Your study and numerous other studies recently have tried to pinpoint the suchness. There's a quality of types of sounds that tend to be misophonia triggers. And when I first went and saw an audiologist for misophonia, she said that not across the board, but generally people with misophonia have slightly better hearing within certain higher frequencies than the average person. And that might contribute to it being worse because misophonia auditory triggers tend to be of a certain quality with a certain type of higher frequency that causes that. Would you say that kind of been your experience as well?
It's hard because, you know, when you look at the papers that are done in different settings, you'll see that the problems that setting is geared toward, they identified more. Like, for example, if a paper comes misophonia patients who end up seeing a psychiatric ward, the prevalence of psychiatric illnesses is much higher than if they were in an audiology clinic. But in an audiology clinic, the prevalence of hearing loss among them and tinnitus is going to be higher. I think that this is somehow biasing this, because of the differences in the populations that this study are looking into. And but I think from my focusing on people with misophonia who do not necessarily go to either of these, I think that their hearing really do not have any problem in terms of hearing loss. But it is better than average. it could be, but I have not seen hard evidence for that.
Gotcha. And you're right. That is something noteworthy. There could be an unintentional bias in that your sample set for this particular research is automatically people who came to an audiologist for some sort of issue. And so they've sort of self-selected in a way, would you say?
Exactly, yes, because they had all tinnitus,
Right.
and tinnitus also has comorbidity with hearing loss, and they've been referred to, and people who are referred to a psychiatric clinic for misophonia, there must be some reasons apart from misophonia that it could be. I cannot be 100% sure, but it is likely that so that population, that would be higher prevalence of psychiatric illness, if you like.
Gotcha. Yeah. More research is always needed. That's what I always say.
Yes.
Before we open it up, we'll take a few minutes here. I wanted to kind of shift gears. Probably, I don't know if it's the most recent, but the most recent thing that you've published that I'm aware of is a commentary on the consensus definition of misophonia. Real quick, just Michelle might be able to post the link to this. I wrote, yep, there it is. The consensus definition, for those of you who don't know, was published in Frontiers in Neuroscience not quite a year ago. And it was a bunch of researchers of misophonia getting together and coming up with a definition of misophonia. It seems kind of obvious, but it was a way of laying a foundation, or an attempt to lay a foundation for everybody to have the same definition of misophonia. Obviously, all of us in this room probably inherently know what misophonia is, but the issue with that is we all have our own impression, and if we're studying, or people are studying misophonia, if they're going off of not a foundational definition of what misophonia is, it can affect the research if we have different attitudes or different impressions of what it is. So I wrote an article. I'm segueing into Dr. Aazh's comment here in a second. I wrote an article for Medium right after that is basically explaining why the consensus definition of misophonia is important. Like, this actually was an important step in misophonia. It's very validating to those of us with misophonia to be able to go to a scientific journal and say, here's the definition of what I have. We don't have diagnostic criteria yet. We don't have diagnostic codes or insurance codes yet, but we have this. This is a step. So I wrote glowingly on it. However, it's not perfect. Like everything, especially in science, is open to criticism. It's open to critique, and that's how science works. Things are published. Other scientists and other researchers and the general public now in droves can look at this particular paper and say, this is good. This is a good step. We're grateful for it, but it also can be critiqued. There are things that are worthy of critique. And that segue is going to the link that Michelle posted from Dr. Aazh, called A Commentary on the Consensus Definition of Misophonia. And his critiques of the definition are really eye-opening to me. Could you give us a little insight on what spurred you to write this? And I can kind of add what I really connected with to it.
Yes, I was not part of that consensus committee, and I think that's helped to be independent, to be able to independently review that. I was approached by the Milken Institute, which actually funded that study, and they commissioned me to look into that paper and write this commentary on this, and independently, and so they basically can be used as the next step after that study, and I agreed to do that. And so the commentary, I think it was a very the consensus itself was a very good action and a study, and it was done in a very systematic manner, and they invited quite a wide range of professionals with various different disciplines, from audiology to neurology, psychiatry, neuroscientists, and statisticians. So they had quite a well psychologists, mix of people in that, and they used the Delphi methodology, which is based on having series of meetings and independent voting and discussions in order to arrive in that consensus about the areas that they can arrive into consensus, and then some areas they can't reach to an agreement, which then will be left for future research. And so I think the consensus basically gave a very good definition of misophonia and highlighted the areas that clinicians can basically use in order to explore the individual experience of misophonia, and in a systematic manner. It talks about the triggers, it talks about social impact of it, psychological impacts of it, and it doesn't really go into the theoretical basis of misophonia, of why do they think misophonia is the mechanism of misophonia and the causes of misophonia, because they are really unknown, and so they do not go into those things. And but then that somehow impacts on the definition, because you are trying to define something that we do not fully understand it. We do not fully understand the mechanism that it is produced, which is a neurological mechanism, psychiatric mechanism, sound sensitivity issue, and a combination of these. And so we don't fully understand this. So it basically impacts on the way that we are going to define something that we are not fully understand. So we have to basically focus on the bits and pieces that we do understand about misophonia, and those mainly are based on observational studies on people with misophonia and the reports of those who experience this condition, that what kind of trigger noises bother them, what kind of emotional reaction, what kind of behavioral reaction they may experience, what kind of physiological responses they may experience, how does this impact on their life, the family life, occupation, hobbies, social life, so on and so forth. So these were the things that were gathered in that consensus. I also tried to add bits and pieces about for future directions on how to basically distinguish hyperacusis, misophonia, noise sensitivity, and others on that paper, which are pretty much the same line of the things that I already have discussed in this meeting.
Yeah, and the two things, thank you so much for that. The two things that stuck out to me were things that you mentioned in your critique or the comments. I don't want to critique. One is the consensus definition sort of laid out misophonia by calling it a disorder. Now, in the medical community, there's a difference between a syndrome and a condition and a disorder. And you came from, in your comments, sort of neurodiversity or neurodivergence viewpoint of saying misophonia it's a little preliminary to say this is a disorder. It might just be a factor of human variance instead of an actual condition that pathologizes what we might perceive as just a normal variance in the human population. And the other thing that I really connected with was the inclusion of who was working on this particular paper. I think there, if I remember correctly, there's about 16 researchers, PhD level, not all of them, most of them PhD level, but Mercede was also on there. And none of the people involved in putting this together, this definition together, experienced misophonia. It didn't include actual sufferers, or there are researchers who have misophonia, Dr. Gregory in the UK and a few others, or just the general public. And so those are the two things that really caught me as, yes, you were absolutely completely correct that the definition in its next version, whenever version 2 comes out, those two things should be absolutely considered. Maybe you can explain a little bit more where you came from for both of those points.
Yeah, absolutely. I think that's one of the things that in these panels you definitely need to have people who experience those conditions, and also this issue of disorder or not a disorder is I think that we understand so little about misophonia that it's too hard at this stage to classify that. It potentially in somebody who do not leave their house because of misophonia, it probably has turned into a disorder, and that is interrupting their life, but it may not be the case for many other people. And then the actual experience of misophonia, I don't think we fully understand it. I think people who experience misophonia understand it, but in terms of the scientific work on it, I do not see a huge amount of work, because there are a huge amount of epistemological and ontological work that needs to be done on this concept. So you have to look at this basically from philosophical point of view. What is it that you're trying to achieve here? Most of the studies that has been done so far are based on this post-positivist approach in philosophy, if you like, which is the science of modern medicine. They want to understand, okay, so if we make some assumptions that, misophonia is, for example, becoming angry or annoyed when you are hearing certain sounds, then you have to make this assumption that this is misophonia. And then you have to think, okay, what are the biomarkers of anger or annoyance or stress? And then you start looking at those biomarkers and trying to see what factors associate with them, what kind of changes in the brain associate with, or your general metabolic system associate with them. So make that sort of assumptions and go into this. But it may not be that assumption, the original assumption may not be correct. And so you may be following a theme of, for example, a defense mechanism. You're mapping a defense mechanism of a person, as opposed to you're mapping the misophonia as a phenomenon. So there need to be a lot of phenomenological studies in the constructivist approach of philosophy, if you like, in order to understand that what is this experience of misophonia. I know that people who experienced it, they know what is the experience. But in terms of the research on this, there are very, very few. There are only maybe 2-3 studies that they were trying to design a questionnaire to assess misophonia. So they had to do some qualitative studies in order to understand misophonia. But their qualitative studies that has been done so far are not by to the level of the depth that you actually require to study this phenomenon that you still do not fully understand. So even I do, I formulated a rehabilitation program for misophonia based on cognitive behavioral therapy. And I think cognitive behavior therapy, compared to a lot of post-positivist approaches in science, is much more closer to resonate with misophonia, because from the epistemological point of view, in cognitive behavior therapy, the feelings, the narrative that the person is talking about, their expressed feelings, their expressed thoughts are all considered as data, are valid data. And and that matters to help to understand misophonia. But cognitive behavior therapy tries to understand misophonia from looking at it from the lens of cognitive theory of Aaron Beck and other people who have developed cognitive behavior therapy in the first place. So it deviates a little bit from understanding the actual experience of hyperacusis, of misophonia. Instead, it tries to see misophonia and understand it from the perspective of CBT. And I think it is close. You can't, with the knowledge, with the methodologies of the day, you can't get closer to understanding misophonia apart from doing this kind of approach, which looking at it and understand that the valid data of expressed emotions, the narrative of the person, and expressed thoughts and experiences that they're talking about, these are all valid information. And so epistemologically, CBT agrees is good fit for understanding misophonia, but it has that theory there. So it's look at it from the lens of the cognitive theory, and it can do that. And it makes sense when you look at it this way, but you are still look at it from a different perspective. You are not trying to understand the actual experience of the misophonia. And I think that is what I'm trying to focus on in my research institute, in terms of focusing on phenomenological studies on misophonia in order to understand the experience of misophonia fully. And that can then later on help us and guide other scientific approaches that can basically go into and assess factors related to this phenomenon. And that's, I hope I didn't bore you too much by.
No, it's a complex disorder or a complex experience, and so there's a lot of ways to come at it qualitatively, quantitatively. We have a question, actually a couple of questions here from Mary Petrie before we wrap up. And if anybody else has any questions before we wrap up, feel free to throw them in chat. Mary says, do you see any tensions or conflict between a biomedical model of health/illness and a biopsychosocial model of health and illness as science works to characterize misophonia? And that's quite a question. She also says, and it seems like CBT is the way it's being described is a tool of the biopsychosocial.
Yeah, this is true. So CBT is a tool of biopsychosocial. So it is more, so in this kind of problems is a better fit tool, if you like, to deal with. I don't think that medical model for misophonia is something that people actually rely on. And so first of all, they do not know the mechanism of misophonia. Even the theories are not really there yet. So I think that's all we have with that. That's biopsychosocial model of misophonia. And but the point that I'm trying to say is that the actual model of misophonia may not be the model of misophonia, because the phenomenon of misophonia hasn't been studied in a manner that gets to the details of it, and you require for a biopsychosocial model to be created.
Gotcha. Yeah, thank you. And these things get, as a layperson, these things get even more complex. There are conditions like depression or addiction or anything that we know very much about the mechanisms of them, but they still don't answer a whole lot of questions. Like there's still so many more questions that come from those. All right, we're almost at time. Does anybody have any closing questions? We have a feedback survey if you have any comments on this. Dr. Aazh, thank you so much. Any closing comments or anything that we should take away from your research, or things that you would like to recommend to us before we wrap up?
Okay, absolutely. So it was a pleasure to be here and talk directly to people who are interested in misophonia and or are experiencing misophonia themselves. And so I am trying to work on various different projects with colleagues from different universities and research centers. And I think it's very good. We have this program of wanting to raise awareness among general public about misophonia. And I think that's kind of is in harmony with soQuiet, your institution. And that, so I think that in the future we can share experiences and events together, which can raise awareness.
Thank you so much. Yeah, it's a big conversation between everybody, all the stakeholders in the misophonia community, the misosphere. Thank you so much, Dr. Aazh, for taking some time out of your evening. I really appreciate your insights. If anybody has any comments or questions, you're welcome to reach out to Dr. Aazh or to me, and we're happy to answer those. We do these science sessions monthly-ish, but I'm grateful for your time, and I really appreciate you helping us learn a little bit more about your work, and we look forward to more in the future.
Thank you very much. Thank you for having me.
Sure. Everyone, thank you for joining us. Have a great rest of your day too. Take care.